Good afternoon. Dr. Matthew Kepman here at Better with Dr. Rock. This is Dr. Matthew Kepman, like I said, and I like to call myself Dr. Rock. However, nobody, including my family, has yet to start calling me that for some reason. Anyways, I am Dr. Matthew Kepman, and this is Better Outside the Box Healthcare with Dr. Matthew Kepman. Hey, I'm in Waterloo, Iowa. And this is one of the episodes where I've been talking a bit about that I'm super excited to have one of my guests who I actually work with. And I'm super excited to introduce not only to the practice, but to all the listeners. And so Better with Dr. Rock would like to welcome Maria Metcalf. So
Thank you.
hey, Maria.
How's it going?
Great. Hey, I just got to say, man, you are a breath of fresh air here into the practice in terms of what you're bringing, new aspects of healthcare that at Kepman Family Practice had not necessarily always consistently offered. How is it for you? How do you like working here? How do you? You're a Waterloo girl, I know, right?
Yep, born and raised. I love it. I love being back in the community. I was here most of my career, and then I left for a few years. It's just really nice to get back and work with everybody here to see familiar faces and all the names of people that I've worked with through the years. So it's good to be back.
Right, and you had to leave for I don't know. Somebody claimed you were the father of some. I can't remember, but they dropped that suit, right? And so no more child support. I love it. It's now clean and free, and now you can work for me. I love it.
That's right.
Or work with me. So actually, you have just to explain a little bit. So you, I believe, are the very first nurse practitioner at Kepman Family Practice who is actually is it a PhD or a doctorate of nurse practitioner? So can you explain that a little bit of the difference between your regular ARNP and MD and a doctorate of nurse practitioner?
Sure. So a nurse practitioner degree is a master's degree. So you have to do all of your core curriculum, all of your specifics to the track of nurse practitioner focus that you have, and then all of the hours that go along with it, obviously, to get certified. A doctorate, it's a doctorate of nursing practice, so a DNP, and it's essentially a 2-year extension where you do a evidence-based practice project. So you can choose a project of your interest, and then you actually implement the program, do some pre and post evaluations, look for some statistical, data that shows that the program that you put together actually was successful, or what kind of things do you need to do to improve it down the road? So you're doing a little bit more of a scholarly activity. So it's a little bit different from a PhD, or a PhD, you do the thesis. This is more an actual hands-on project that you put together and actually implement and put into practice and see if you can improve patient care.
That's so cool. So thank you for clarifying that. So one of the premises of Better, and one of the reasons I started this podcast, a lot of the reason I started was for my practice and for the people who maybe they've been with me or they've been with the practice for 20 years, but I haven't been able to see them as much as we've gotten busier. But I still want to reach out to them, and I can't. So I want a platform to be able to teach. But the premise of this, whoever's listening is better. Is I want to offer actionable items that somebody can take to their doctor, or even if it's like an over the counter or a lifestyle change that's easy, that's something that is, I don't want to tell somebody that, hey, if you climb Mount Everest next year, your life's going to get better. Well, wow. Sure. I want something that people can do. And so one of the goals today with having you is you've changed some lives. And I think that we're going to talk about sleep apnea a bit. And I think you have a ton of experience there, and you've seen some stories that you could share with us that are awesome, because I think there's a lot of fear around sleep apnea, and people are scared to even get diagnosed. They're like, you ain't putting that mask on me. No way. And they're done. And they won't even get tested. Yeah. And so if you could clear up some of that for some of the listeners, I think we would do a service for sure. And do you believe this? I don't think I'm on call, but here's the answering service. We're going to cut that part out. Hold on. Hello? Hello? Yeah. Yeah.
The lawyers made me say what you all know anyways. This podcast does not create a doctor-patient relationship. Please listen to the short, informative disclaimer at the end of this podcast.
Hey, I'm Dr. Matt Kettman. Around here, they call me Dr. Rock. Well, I wish they did, but welcome to Dr. Rock's Family Practice, where we tackle health with straight talk, big laughs, and real solutions. No fluff, no nonsense.
Good
just the
afternoon.
tools
This
you
is
need
Dr.
to
Matthew
live your
Kettman,
best
like I
life. Let's
like to
get call
start.
myself Dr. Rock. However, nobody, including my family, has yet to start calling me that for some reason. Anyways, this is one of the episodes where I'm super excited to have one of my guests who I actually work with. And I'm excited to introduce not only to the practice, but to all the listeners, Maria Metcalf. So,
Thank
hey,
you.
Maria.
How's it going?
Great. Hey, I just got to say, man, you are a breath of fresh air here in terms of what you're bringing. New aspects of healthcare that at Kettman Practice had not necessarily always consistently offered. How is it for you? How do you like working here? You're a Waterloo girl, I know, right?
Yep, born and raised. I love it. I love being back in the community. I was here most of my career and then I left for a few years. It's just really nice to get back and work with everybody here to see familiar faces and all the names of people that I've worked with through the years. So it's good to be back.
So actually you have just to explain a little bit. So you, I believe, are the very first nurse practitioner at Kettman Family Practice who is actually is it a PhD or a doctorate of nurse practitioner? So can you explain that, a little bit of the difference between your regular ARNP and MD and a doctorate of nurse practitioner?
So a nurse practitioner degree is a master's degree. So you have to do all of your core curriculum, all of your specifics to the track of nurse practitioner focus that you have, and then all of the hours that go along with it, obviously, to get certified. A doctorate, it's a doctorate of nursing practice, and it's essentially a 2-year extension where you do a evidence-based practice project. So you can choose a project of your interest, and then you actually implement the program, do some pre and post evaluations, look for some statistical, data that shows that the program that you put together actually was successful, or what kind of things do you need to do to improve it down the road? So you're doing a little bit more of a scholarly activity. So it's a little bit different from a PhD, or a PhD, you do the thesis. This is more an actual hands-on project that you put together and actually implement and put into practice and see if you can improve patient care.
That's so cool. So thank you for clarifying that. So one of the premises of Better, and one of the reasons I started this podcast, a lot of the reason I started it was for my practice and for the people who maybe they've been with me or they've been with the practice for 20 years, but I haven't been able to see them as much as we've gotten busier, but I still want to reach out to them and I can't. So I want a platform to be able to teach. But the premise of this listening is I want to offer actionable items that somebody can take to their doctor, or even if it's like an over the counter or a lifestyle change that's easy, that's something that is, I don't want to tell somebody that, hey, if you climb Mount Everest next year, your life's going to get better. Well, wow, sure. I want something that people can do. And so one of the goals today, having you, is you've changed some lives, and I think you have a ton of experience there, and you've seen some stories that you could share with us that are awesome, because I think there's a lot of fear around sleep apnea, and people are scared to even get checked. You're not putting that mask on me, no way, and they're done, and they won't even get tested. Yeah. And so if you could clear up some of that for some of the listeners, I think we would do a service for sure. I truly believe that every episode I want to be reaching somebody out there who has not heard, even if it's a simple message, who has not heard something that may save a life or a marriage, or because I've seen it, you've seen it, simple misinformation or lack of information or understanding, or even bad medical care can I don't want to use an F-bomb, it can mess up somebody's life, right? A false belief. So before we talk about sleep apnea, though, I would love to hear a little bit about your personal background. Do you have a family? Where'd you grow up? Your parents?
Yep. I grew up here in Waterloo, graduated from Cedar Falls High School. Married. We got married in, 1997. I almost forgot. We have 2 boys. They are 23 and 25. They are both graduated from college, and one is working successfully up in Minneapolis. The other is in Des Moines. He's struggling to find a computer science job. Apparently, they're all on freeze right now, but he's looking and trying to get something. My husband works for Blackhawk County. He's the safety coordinator for Blackhawk County.
He's a great guy. So
Yes.
now that we know a little bit about you, can you tell me a little bit about how you ended up here at Kettman Family Practice? Where did you start? So you went to Allen College, right?
Yep. So way back when, I did the diploma program. So it was a 3-year program at the time. I'm old. They don't even have those programs anymore. Then I did go back and get my bachelor's degree and then decided I wanted to teach. So I started and did a master's in nursing education through Allen, had taught full time through Allen, and then realized I really missed patient care, like that direct patient contact. So then I went back and did an adult FNP degree through St. Louis University. And then after that, I decided I didn't want to be limited to adults only, wanted to open it up to children as well. So I got my FNP, and then I started working in internal medicine, did that for a couple of years. As an RN, I spent most of my career in I did medical oncology, I did ICU, and then neurology as an office nurse. And then that's really when I fell in love with neuro. So I knew that at some point I wanted to get back into neuro as a nurse practitioner. I think I've been an NP now for about 15 years, so probably at least half of that or more, actually more probably, is in neuro. When I was working in neurology in Cedar Rapids, when you reached out one day and eventually wore me down and talked me into coming to family medicine.
That's what I did. That's what I did to my wife, actually, too. So why don't you tell us a little bit about the wearing down process? Because I think that's just an awesome story, especially if you know nothing about me or what it's like working at Kettman Family Practice. This is gonna blow your socks off. So tell me, did you know right away you wanted to work for me? Did you even know who I was or we were, or tell me?
Yeah, I had met you a little bit through the years, had talked to you a couple times about neuro things like Botox for migraine, things like that. And although I don't think you remember meeting me, but I do remember meeting you. But it was, September, maybe a couple years ago. And I got a text from you randomly. And at first I thought, oh my gosh, how does he even have my number? There's no way this is really him. And then I think I responded and said, well, maybe we should talk. So then you had, I think, maybe texted me almost every day until we finally spoke on the phone.
Yes.
And then we spoke on the phone. Then again, it was, a mirage of texts that you just kept bombarding me with. And my husband was even like, who is this guy? What's going on? Why is he texting
If
me
there's
so much?
single women that I know out there, they know this pattern.
Yeah. So eventually through texting, I was in love with neuro. I didn't want to leave neuro. I wasn't looking to leave. So it was kind of a big deal for me to even consider leaving that position.
Sure.
But talking to you was enough for me to at least want to talk to you a little bit more and hear about it. I was driving from Waterloo to Cedar Rapids every day. So that was a big deal for me. But I didn't want to take the job just for that convenience. I wanted to make sure it was a good fit. So we did finally meet, several of us over dinner that one night. And you guys are all amazing, comfortable group. Everybody just felt like I've known everybody for years and that we were longtime friends. So it just felt very comfortable. And you guys asked the right questions, said the right things, and it just felt like a great fit.
Come on, it was not that smooth. You had the full Dr. Kettman. I think
did.
I was caffeinated a little bit that night. It's been a couple of years since I don't really drink alcohol anymore. So caffeine's my only good time. So listen, you got the
You
full
talked
experience.
a lot
Actually,
about your guns that night.
I was making guns. I had worked out that day and I was like, I don't know if I can cross the state line with these guns, right? Kind of jokes.
Yeah.
But lots of dad jokes. I think even before we had this meeting, I think I was a little concerned that I wanted you to understand weren't just your regular family practice office, that this is fun. Now, it's not fun every day. Would you agree that we take care of some really challenging and complex patients that make
Very
it
complex.
sometimes, yeah. And we don't turn a lot of people down. I really feel, and maybe you can give me some feedback on this, I feel like we take care of a lot of people who aren't getting somewhere with someone else for whatever reason, and they somehow make their way to our office. And a lot of times these are intense relationships with lots of visits and times a lot of social, they draw you in and you're taking that stuff home sometimes. It's intense. But it's
Yeah.
also so rewarding sometimes. I mean, I don't go to the hospital anymore, to be at the bedside when somebody dies, a privilege, if you think about it, really, that a family would allow you as a physician there, or in the home. I've been there for that as well. So tell us about the difference there you're seeing, like in family practice and neuro, in terms of risk, but also reward and demand.
And neurology is a very unique specialty, I would say, because most of the people that come through neuro are chronic illnesses that are not likely to get better. They're likely to worsen over time, and we're very limited in what we have for treatments. And so there's not a lot of times that we get to see them improve or have a cure and then be able to go on and live a happy life. A lot of it is very progressively worsening over time and takes their toll on the patient and their family. So what I see here is it's a broader spectrum of things. Like I might just see somebody for a cold, which can be a terrible thing also, but we can get them better. Or we see very many complex illnesses as well here that we can at least try to plug them into the right direction. Or like you said, if we don't feel like they're getting the care they need outside of our office, what's cool about you in this office is that you're willing to take on those things and we can help them in any way we can. So if we're going a little bit above and beyond what we normally would as a family practice office, we can do that. And we've been able to do that. And I think that's a really neat thing. So I've been able to help people. I've come across more intense neuro cases here than I have in my neuro offices.
That's
So
so
I think
cool.
that's kind of interesting
Why?
too.
I've noticed that, like, listen, not that I figured out early in my career that I probably wouldn't have been happy just seeing colds and strep throat all day, but I don't understand, how do we get these really complex patients for a family? How did we turn from, like just your routine? Because I don't know if a lot of people know this, but your typical family practice office is not supposed to be set up for really complex older patients. That's typically internal medicine, really complex psychiatric patients. But we have a lot of both, I would say. In addition to complex specialty cases that we can manage or co-manage with some of the specialists. So do you feel like we overstep our bounds sometimes, or what's your adjustment been with that? Because I got to figure in an office like this before.
No, I have not. No, I don't think that we're overstepping anything. Obviously, we're all aware of where our limits are and when we need to pull in those specialists.
Sure.
But I think it's neat when we recognize something that we know they need, and then we can go ahead and work on it and get it for them and maybe get answers or get treatment that maybe they wouldn't have otherwise.
Yeah, that is
And I
cool.
think other offices are really quick, maybe in my opinion or my observation, that if they see something that's outside of what a family medicine would be considered to do, they will just send off automatically. Where here we are willing and wanting to dive in a little bit deeper.
I think that's part of it too. And honestly, it's not that, we have some great specialists in town, but we are a little underserved. And so in some areas, we've had to periodically over the years, we've had a shortage of a certain specialty. I've had to learn how to do certain things. For instance, probably got into psychiatry type stuff, which family practice has to do a lot of that anyways, but probably got into that a little bit because of the lack of access. I would see my people and they would have these symptoms which were tied to their psych, but you knew it was physical, but
Right.
and you'd be like, okay, well, call your psych. And they're like, okay, I can't see him for 4 months. And so I'd be like,
Yeah, they
well,
can't wait that long. They need
right. And I'm
something
like,
now.
well, what is this olanzapine? It says here if they're having depression or insomnia with their bipolar, turn it up by 5. And I'm like, okay, well, no one's returning my call. Let's try that. And that's kind of how that went. Some of that stuff, when we get a good doctor in a specialty, I'm happy to give right back. What do you, aren't you?
Yes, absolutely.
I still feel even with us taking all that other stuff on, there's still a need for all the stuff that we kind of left behind, there's still a need for primary care.
Right. And I love the preventative side of things too.
Yeah, you're really good at that. And sitting down with people and explaining that, I've heard some really positive feedback on that. So awesome. So for anybody that doesn't know Maria, she's our newest provider here. And like I was saying a little bit earlier, she has a lot of experience with sleep apnea. And anybody that is in our clinic getting a CPAP, sleep apnea type of supplies, routinely from us, trying to get you in to see Maria at some point because we can turn these machines for you instead of against you, where I might not have been doing the best job. And I'll fully admit that. I haven't trained any of our providers to do an awesome job about it because the truth is in family practice, you kind of got to pick and choose. And if somebody's on, there's so much. And if somebody's on a CPAP and they feel good, well, I'm probably going to leave that alone. And so they've got other things going on. Some of our people probably could have been better served. At the same time, I know a lot of people have been a little bit more resistant to maybe seeing us for one or two more visits here. And we have to explain why we can help them with their SAP in a way that I have never done or any of Katie or Mary Jane haven't. Can you tell us a little bit about that specifically for people in our practice who have been on a CPAP for many years? They're doing fine. Why would they want to come see you?
There's a lot of monitoring that needs to be done that I don't think historically, not even just your office, but in many offices, that this monitoring doesn't get done. And that's one thing that I really learned through working neurology, sleep medicine, is how much more is involved in monitoring. What pressures are you at? Is it enough pressure? Are we correcting the sleep apnea? Are you feeling better? Are there ways that we can improve some of the settings or the mask fitting? So many aspects of it that it seems really simple, but when you really get into it, sleep apnea can be very complex. So it's just a matter of monitoring and making sure that we're utilizing the machine the best we can.
Okay, so as a message not only to our patients, but to providers that might be listening, you're saying that just if they feel fine, leave it alone is not good enough.
Not necessarily. Like, it's fine to run a spot check at least once a year just to make sure that those settings are still good. But you can have patients that say, yeah, I feel pretty good. Or what they think is their normal and is their good is actually really bad, and we can improve it and make it better. And then help them realize that that you weren't controlled. You don't have to feel like this.
And that's where I've seen probably the biggest difference in terms of our sleep apnea patients that you've been working with. Typical example would be somebody I'm seeing for blood pressure or something twice a year, and they've been getting a CPAP for a diagnosis for a long time. And 10 years ago, it really made them feel better, and they feel fine. And I say, hey, I've got this provider now who kind of knows a lot more about this kind of stuff than I do, and we haven't looked at this in a long, long time. And I don't really know even how often it should be checked, or my John Deere people will be like, hey, it's been 5 years. I need a new machine. I'm like, okay. So they a lot of times, I think the patients even know more than we do as providers. I've had these people come to you and actually have seen them back many times. And we've seen that even though they thought they felt fine, with some tweaks that you're able to make just by kind of downloading some of the data from their machine, you can actually redefine their fine. And so what would you say to somebody that might be listening who has been on a CPAP for sleep apnea, who it hasn't been checked in several years? Is that something that needs to be done?
Absolutely. Like I said,
How
a
often?
minimum of once a year. But if we are struggling or we need to make some changes and things, then I'm going to be repeating the compliance download at least maybe in 4 weeks, maybe 8 weeks. It just kind of depends on how bad the settings were, how bad the numbers looked, what kind of big adjustment am I making. So I do tailor it for the person. There isn't necessarily cookie cutter, but I would say at least a minimum of once a year just to do that spot check.
So they need a repeat sleep study once a year?
Nope. We're just running it all off of the compliance data off of the machine. So that
They just
machine
need
provides
a
all the data
download,
we need.
just a visit.
Yep, just a visit.
Oh,
We need to be able to access the machine, get that data, and do it from there. Now,
okay.
sometimes, depending on the situation, maybe when their last sleep study was, if they need new supplies, if they need a new machine, there may be insurance guidelines that says you have to have a repeat sleep study.
Yeah.
Also, everybody who's had a sleep study prior to Medicare and then they become of Medicare age, they all have to have a repeat sleep study at that point. So Medicare doesn't want to pay for anything unless they know that they truly have sleep apnea. So we just have to do that confirmation. And most of them are all done in the home now, which is really easy and comfortable.
Okay, so I think there's some low-hanging fruit for some listeners out there who are wearing a CPAP who haven't been tested in years, because I think that's pretty common, wouldn't you say? I think in primary care, we just have so much to do, right? We got to put the dangerous stuff top, right? And so, not that sleep apnea is not dangerous.
Right.
So what about this? So I think that's a good point that somebody could take away and possibly improve the quality of their life on better. What about this, though? What about somebody who should, by all means, have sleep apnea? They're maybe really overweight. Everyone in their family has it. They feel terrible. but they've had a test and it was normal. And so they're like, no, I don't have it, Is that true then? Can they say it to their forever for 10 years, for 20 years? Or do we miss them? What if it was an in-home one? Are those less accurate?
Yeah, the in-home ones are less accurate by about 30%. So if I order a test on somebody who I am certain must have sleep apnea, I'll do the home sleep study first. If that comes back normal, I always follow that up with a polysomnogram, which is the in-lab sleep study. That's where they are.
What was it? A poly? I mean, please. Yep.
Polysomnogram. Yeah.
Yep.
So that's where they're hooking up to the EEG monitor. So they're doing all the brainwave activity, making sure that they're passing through all the cycles of sleep. They got them hooked up.
So a home one is not a polysomnogram.
No. The home one only is monitoring your oxygen level, your heart rate, and your snoring.
So what does the home one look like? They don't have all these straps on?
They have a few different versions out there, but the main one, there's a strap that goes around your chest, and then that has a lead that goes to a pulse ox on your finger, and then a nasal cannula. There's a few different versions. One actually will adhere to your chest, and maybe a pulse ox on your finger. But the in-lab is much more extensive, where they have you on the EEG monitor, the heart monitors. They have you on limb monitors. So they're really looking at everything.
And more accurate.
More accurate, yeah.
Okay.
Like I would almost say near 100% accurate.
So how do you decide which one to start with?
Insurance pretty much requires the home sleep studies now. So that's always the initial step, because a lot of times we can get the good enough diagnosis off of the home sleep study. If the home sleep study comes back positive, then I would say that you definitely have sleep apnea, and that it's probably 30% worse than what those numbers are showing. But if it's coming back normal, then that could be falling in that 30% of false negative reports. So then that's what we follow up with the polysomnogram. Okay,
so there's really probably a lot of people walking around who've been told they don't have sleep apnea who do. You're saying like maybe 30% are missed?
Yeah, so that's the accuracy of the test. But what I know from recent statistics, there's about 30 million people across the U.S. walking around with sleep apnea, and only about 6 million of them have been diagnosed.
Wow.
Yeah, it's a huge number.
Okay, and tell me, and maybe I got ahead of myself. I really wanted to get that message out, because I know there's people out there who have had the test and have been told, and by all means, it should be the answer. But maybe I got ahead of myself. Maybe we should talk about what is sleep apnea, for anybody that's listening and doesn't know that, because I want to help people, but maybe I'm just assuming that everyone knows what sleep apnea is. So what would you say to someone who's never heard that term?
Yeah, so I feel like people who have talked about sleep apnea or seen other people with sleep apnea, they just think it's snoring. I snore at night. I have sleep apnea. It's fine. It's no big deal. But it's so much more than that. So what we really look for are two main things. There's apnea and there's hypopnea. So both of these things occur and your oxygen level drops while you're sleeping. So apnea is when you actually have moments of time where you are not breathing. For it to qualify as an apnea event, you have to not breathe for 10 seconds or more. A hypopnea event is you're still breathing, but your oxygen is dropping for whatever reason. So the typical cause for that is when we're relaxed, it's called obstructive apnea. That tongue just falls back into the throat, kind of blocks the airway and interferes with how much oxygen we can pull in. So if we can so what happens during the sleep studies is they measure and count how many episodes of apnea do you have, or how many times do you stop breathing, and how many times does your oxygen level drop. Then they can take all of that, divide it by the number of minutes that you sleep, and they come up with what's called an apnea-hypopnea index, or your score. That score tells us how many times or how many events this happens every hour while you're asleep. So anybody who has more than 5 episodes every hour, it's considered a positive sleep apnea test.
So you're saying it can be normal to have some low oxygen events or some stop breathing events?
If you don't have too many of them, yes, then we would consider that. It's like everybody's allowed 5 per hour, but anything more than that, we would say that's a problem. And then
we'll
we
allow
rate
5.
it.
We'll allow
5, and that's it. Yeah. Then we go mild, moderate, severe after that.
But right. Don't drive after more than 5. Okay.
Right. So then after that, it's what's happening underneath, like what's happening to your brain, to your heart, to all of your internal organs. We know that that's starting to take its toll, and it can actually cause heart damage. It can increase your risk for heart attack, increase your risk for stroke. There's actually been studies that show that untreated sleep apnea patients, they've done MRIs of their brains, and they will show damage to the brain. And they treated them for 1 year on a CPAP, and all of that brain damage reversed, or almost all, I shouldn't say all, but most of it reversed. So the CPAP and doing the proper treatment can really improve your overall health. So I guess my message is it's not just snoring. It's affecting your heart. It's affecting your brain, your internal organs, your ability to think. It hits you emotionally, mentally, physically. It's your whole body. And I have posters up in my rooms and I have patients come in and they'll read it and they're like, I have every single one of these symptoms. So then that's usually my trigger, like, okay, then we need to do something about this.
So, okay, listen, I think that was an awesome explanation for sleep apnea and why somebody might need to get tested. What if you know somebody has maybe your loved one who probably has it and you're concerned about them, but they've said, I'm not going to wear that thing. I even get tested. Maybe they did try to wear the thing for a couple nights and I can't sleep with this mask on my face. And it was done and then it's been sitting in a closet since. So about those people, is there any help for them?
Yeah, there's a lot of different treatment options. So we don't have to go directly to a CPAP, although I will say that CPAP is the first line treatment for all levels of sleep apnea. But the other things that we can see in the sleep study is like what position are you sleeping in when the apnea events are happening? So a lot of times that will happen when you're laying on your back. That just makes it easier for the tongue to fall back into your throat. So if we can look at, let's say you had 50 episodes during the night and 45 of them happened on your back. Well, let's get you off your back. So they have positional pillows that you can actually Velcro around your chest that prevents you from rolling onto your back. So it keeps you on your side. You can put the head of your bed up. Those two things in themselves will help prevent the tongue from falling back. There are dental appliances that you can get. So you can get them on Amazon or any of those places, but truly a good dental appliance, you want to have your dentist actually do the mold of your teeth. Then it puts a hinge at the jaw, and that hinge will push the lower jaw forward, which then pulls your tongue forward and prevents it from falling back into the throat as well. That can work for a lot of people. Insurance doesn't always like to pay for that dental appliance, which is why I think people go to Amazon a lot. The quality is not quite as good, but you can still see if it might help some. But anyway, the dental appliance can help really well. It's just kind of a risk because it's not a guarantee. Like a CPAP is a guarantee that it would correct your apnea. The dental appliance could help, but it may not correct it entirely or enough. So usually if I have somebody doing a dental appliance, then I'll follow up with the sleep study while they're wearing it to see if that actually cleared it up and if it did enough or not. Then we have to look at, okay, so is there something surgical, something anatomic that's happening? So do you have something with the sinuses? Do you still have your tonsils? Is your uvula really large? So they can, like an ear, nose, and throat surgeon could evaluate to see if there's something surgical that could be done to open things up and actually improve apnea from there. The CPAP, I don't think sometimes people give it enough effort. So I tell patients it can take anywhere from 2 to 6 months to really adapt and train your brain to learn how to sleep with that mask on. So it does take a lot of consistency and like over and over, I have to try this. We can do adjustments to pressures. We can do adjustments to the mask or to the headgear to make it more comfortable. So there's always more things that we can do to help. There's never a time where we should say to you, nope, this is it. You have to make this work. There's always something we can do.
Okay. And in terms of people who don't like how it looks, do they make them in like a Darth Vader helmet or like the Gimp from Pulp Fiction? Okay.
God.
All right. No, nothing? Okay.
Not that,
sorry.
but
all right. Well, that's a legitimate concern then, right? So,
yeah,
okay.
I mean, that is a true, especially like I'll hear from women all the time, like that's just not sexy. My husband's not going to like that, or I'm going to be embarrassed to wear that in front of my friends or my husband, so it's a matter of just really trying to educate that. So this thing could actually kill you. You're 3 times more likely to die if you have untreated sleep apnea than if you're treating it. So, if we can help them understand the depths of it, that again, it's not just snoring, it's affecting so much more that, maybe we can look past just the aesthetics of it and know that you're going to be around longer for your family and your husband if you wear it.
I see. So it actually does affect how long you live.
It
Or
does.
it can.
It
Okay.
can, yeah.
So they should be a little motivated.
Yeah, you would hope. But
Okay.
I get it. It's uncomfortable. It's hard. I don't even wear one, but I work with so many patients. I've worked with so many through the years that I have heard almost every description of the terrible things that they go through while they're trying to adjust. So it's just my job to see what I can do to help them. And I work really closely with the respiratory therapists in town. We have a pretty good program to try to do whatever we can to make it easier and more comfortable.
Okay. Well, I can say that there are definitely those miracle stories of people who didn't like it at first, but then pushed through and ended up loving it and will never go anywhere without their CPAP and will never even take a nap without it because it makes them feel so much better.
So much better.
You've seen that before, right?
Oh, lots and lots. Yeah.
But would you say there are people out there who have really given it the old college try and it's just not going to work out?
Yeah, there are. We've done everything. They are just uncomfortable. They get claustrophobic. Then we have to start looking at those other things. Like that's when we would maybe go to the dental appliances or a surgical evaluation to see if there's something to be done. There is also the Inspire device. I'm sure those Inspire commercials are all over. What they don't go into is any detail at all about what a true Inspire device is. All they say is you don't have to wear the CPAP anymore. So this is a great thing. But what they don't explain is it's an implantable device. So you have a battery pack in your chest. There's a wire that's fed up to the nerve that controls the tongue. And so you turn this device off in the morning so you don't have it on during the day, but at night you use a magnet to turn it on. And then as you're laying down, that wire can detect if your tongue is starting to fall back into your throat. And as that tongue falls back, that wire will send a shock through it. And that shock sends your tongue forward out of the airway. Yeah, like people can feel that.
I have
And
a patient who
sometimes,
can't turn it up enough to treat himself because it hurts.
right. Yeah,
Yeah,
so
but
that can
it
be an
can
issue
be
too.
awesome.
There's lots of
So
settings that they do with that too. So it's a interesting development in the treatment of sleep apnea for sure. It's just not for everyone.
like you obviously know what you're doing with sleep apnea. I can witness or attest to anybody out there that hasn't seen Maria that she's definitely made a difference in, especially the sleep apnea patients, especially if you've been chugging along for years with no one really telling you. Oh, it's not the only thing you do. You are a family practitioner. And so you can see anything from colds to now even bipolar depression, right?
Right.
But
Yeah.
but in some areas of family practice, I guess I should say both family practice and neurology, you've really upped our game. And one of those is headaches and migraines. And that's actually one of your passions, I believe.
Yeah, yeah. I think that migraines are one of those things that when people have them, you're just miserable, you're suffering all the time. And there's so many treatment options now that maybe people aren't aware of that we can broaden and better their health and their overall like day to day. I love that I'm able to do Botox for migraine here too. So that's kind of one of the steps in treatment, depending on, where you're at and how many you're having, all that kind of thing. But yeah, there's so much we can do. So it's definitely one of my passions and love when I can help people with in that way.
Okay. So would you say if someone's like disabled from their migraines or still having 2 or 3 days out of commission a week, that they've, in general, a lot of those people really don't know some of the newer options?
Very potential, yes.
I mean, there's still people who aren't going to respond, but I
Right.
would agree. What I've seen is some of these newer migraine medicines, both to prevent you from getting them, or what we call prophylactic daily medicine, and the rescue medicines, although they're very expensive, they're actually cost beneficial because they're keeping people out of the ER. Would you agree that some of these newer CGRP type of things are pretty amazing?
Yeah, they're kind of game changers. They
They
can
really are.
significantly reduce just the frequency or even the severity of the headache. The rescue or the abortives that I call them, they can actually stop the migraines altogether so that you don't have to suffer, or maybe you'll just have that lower grade headache where you can still stay at work and do the things that you would normally do that day.
Sure.
Yeah, they've been great.
So another message I think that gets that doesn't get spread enough is that number one that I see is that you don't have to live with these headaches, correct? And I think a lot of people went to the doctor 20 years ago when that might have been true. And number two, I think that a lot of people don't realize that when we talk about migraine treatment, that we're talking probably about treating those even annoying slight headaches that you just called, those are my headaches, not those aren't migraines, right?
Right.
Would you agree that a lot of what we used to classify as different types of headaches has really just kind of changed into let's treat it all as sort of this migraine thing?
Definitely those migraine patients have the daily headache component to it as well. Or even people who don't have the severe migraines or as frequently still have those daily nagging headaches, which I could also tie back to untreated sleep apnea because that headaches is one of the number one symptoms of untreated sleep apnea. So
Oh,
that'll often be one of the parts of my workup when I'm trying to figure out what's going on is, is it coming from the neck? Is there some tension? Is it muscular? Or do you have an underlying sleep apnea? Or, can we find what the cause is and actually identify it, treat it, and reverse the headaches for you? Or is
sure.
it just going to be a chronic issue that we have to learn how to basically get it down to controlled as much as we can with those medicines?
Okay. Well, I'll tell you what, I have to say there are some of my patients that before Maria came did not have their migraines under control. And there was a number of my patients who actually thought that their migraines were under control, but they were still having these little annoying headaches that didn't necessarily take them out of commission. But they didn't realize that those weren't something that couldn't be addressed and that we could actually up our migraine treatment game and knock those out of commission too. And so I think educating people has been something that you really like to do, that you've done well here. Do you agree?
Yeah, I think it's important to know kind of the basics of everything. So if I'm going to give you a diagnosis, I need to tell you what that is, because otherwise, how are you going to know what you can do to help yourself and to know what I can do to help you as well? So
Okay.
understanding your illness or your disease process, condition, whatever it is, I think is
Okay. Awesome. Well, I'm going to have you as a recurring guest, and you have a message to deliver to multiple messages because you currently write for a publication with the Courier that comes out once a month. Is that correct?
yes, I do.
Tell me about that.
So it's just I've been wanting to get into more health writing, and so I reached out to the neighbors of Waterloo, neighbors of Cedar Falls. I think there's Waverly too. So I do just a monthly health topic, health corner piece, usually on just anything within health. Could be literally anything. So if anybody's got topics out there they want more about, I can write about those too. So it's just providing something for
Awesome.
the community. Yeah,
And are you still teaching too? Is that right?
I teach too.
Tell me about that. Okay.
Yeah, I teach in the nurse practitioner program at Allen College.
That's
Um,
badass. That's really cool.
It's awesome. It takes
Allen's
a-
got a great college. Guys, that's an amazing resource to this community. The Allen College has put out so many quality, I mean, like quality nurses, quality nurse practitioners, some quality like radiology type people, techs and whatnot. Is that
ultrasound. Yeah, they're expanding more and more physical therapy, occupational therapy. It's really grown.
that's awesome. And so is one of your titles Professor Maria Metcalf?
Yes, I am.
Oh, that's awesome.
Full professor.
Hey,
Yeah.
cool. That's badass.
Yeah.
So, okay. So I know we don't have that much time and I want to kind of wrap it up. And they actually, my podcast coach told me to keep the interviews around 45 minutes because you're not Joe Rogan, who apparently goes 3 hours. So a couple things I wanted to, let's just touch base on. First of all, do you, anything else, whether it's family practice or neurology that just gets under your skin that is like one thing that if you had the entire nation listening to you right now today and you want to improve their health or even just to get a better visit when they go see the doctor or improve their marriage or something, a piece of advice that you wanted to pass on that they should remember, even if it's repeating something you've already said, what would that be?
Oh boy, that's a tough one. I think one thing that I go back and I've told my students this, so it can apply to different ways, is you get out of something what you put into it. So if you are half-assing your health, that's what you're going to get out of it. So you really have to pay attention to your health. What are the preventative things? Is it smoking? Is it drinking? Is it eating healthy? Is it getting some exercise? Is it just water, taking your medicines, following the advice of your healthcare providers? If you aren't doing those things and you're feeling miserable, you're feeling lousy, then that's the first place to look is, well, what am I doing for myself? What am I doing to help myself? Or what am I not doing that I should be doing? So I feel like that's a big part of it is you have to, we can do so much to help you, but you have to be there for yourself and to really step up and take care of yourself as well. If you're not taking care of yourself, then that makes it hard for us to take care for you too. So, and that can go for so many aspects. If you aren't putting everything into your marriage and you don't feel like your marriage is where it wants to be, then what more could you do? That applies to every aspect of your life, I think.
Awesome. Thank you. Okay, now I just have a couple fun questions for you. Okay, so tell me your favorite thing about working a part of the team at Kettman Family Practice.
You guys are amazing. From the first day that I walked in, I've just felt part of this family. Everybody is so great. Everybody gets along. There's always some fun that has to be had. We enjoy getting through the days. Like you said before, we have some rough days, but we still know that we're doing everything we can to help the patients. And that's ultimately what it's all about. What can we do to help people? And do we feel like we made some difference today?
Sure.
And I feel like we do that.
Does the fact that I don't wear pants a lot of the time bother you professionally or not really?
I've really gotten used to it now. So
Okay,
I just
okay.
look head up and we're fine.
No, but we do have some fun, don't we?
Yes,
We have some humor here.
Yep.
How long did it take you to realize don't believe anything I say unless I say it's something you got to really believe?
So like 20 minutes.
I know, right? Am I wrong when I describe, I think I told you this before you started working here. I said, I'm like your kid brother, but I'm a doctor. Is that, I'm
Yep.
your annoying kid brother actually was the
Yes,
term.
yeah, I think you did use
my
annoying.
nurse, Lindsay, uses a lot. So
Yeah, I'll hear
Anyways,
that from day to day.
I love it. And tell me what's your favorite, and this is the last question. What is your favorite thing, some of the favorite things that you have about the practice and the people that we serve?
I love the variety of things. So I never know from day to day what I'm going to see that day. I don't usually look ahead at my schedule. I just try to take everybody one at a time. And so I love the variety of things. You might have a really simple visit. You might have a very complex visit. It could be an emotional visit. It's everybody comes in with, whatever's happening with them at that time. And I love trying to be able to help people through all of their, whatever it is, all of their events in their life and feel like they can help them.
Oh, we have some rich relationships with our people, don't we?
Very
It's
deep
awesome.
relationships.
I mean, how many times do we have? I mean, I mean, all the time, but do we have like tears with them and holding hands? And
Absolutely.
I mean, sometimes I'm even praying with them or praying over
Yeah.
them. It truly, although sometimes it is super frustrating and it causes sleepless nights. And sometimes, no matter what you do, you feel like you don't make a difference or that no one cares, right? But just about when you're about done, then one of those moments puts it over the top, and you're like, "This is why I do it."
Yep.
And
This is it
and
right here.
and the people that we have attracted to this practice, although they may be difficult to manage, and they come with a lot of times previously explored symptoms, and sometimes they're suffering a lot.
Right.
And maybe they're here because they haven't gotten help. And I'm not saying we do anything better than anybody. Probably just as many people down the road that have left us to go find help elsewhere, but they're here for a reason. And to get into somebody like that, you really got to invest more than just paper and pen, right?
Yeah.
And it can be, although it can be drain on your soul, that's hard to restore every day. It's hard. It's a hard battery to recharge because you take it home. When you get those moments, it's absolutely worth it.
It is. Absolutely.
It
And I would
absolutely,
definitely say we all invest like 100% of ourselves into every patient.
every single one of our team is awesome at that. And our team is amazing. Every provider is amazing. From the front desk to the last nurse, but to my mom who
Yeah.
works here. But honestly, the caring is what I think puts us over the top. And I just can't believe how lucky I am to have found all these people, and you included, especially you and your nurse. It's just been awesome. And I look forward to continued growth with our colleagues, with everyone that works here, and all of our patients that have been here. I mean, I have people that I've been seeing since the very first day I started residency.
Yeah. I've met many of them.
I have people
They-
I delivered like some of the very first babies when that was a thing that I was gonna do. Are my adult patients now, and that's a cool feeling. And then that's the other thing I love here is just the fun that we have, the humor. Even in times of stress, there's always there's jokes and smiles, and it really even. And this is the other thing I found in family practice, and I don't know if you saw this in neurology, but I mean, you can even have humor in the face of hard times. You can be at. I mean, I've been at like a funeral for a child, which would be the most god awful thing you could go to, and you still can, whatever, just if it's the right time, just something
Right.
innocent, a dad joke, and
Yeah.
if it was the right time, at the smile and the warmth you can bring to that situation, I think sometimes is I think you do more good than whatever.
Yeah. Just to pull them out for that moment. And
Yeah.
Yeah. Give
Yeah,
them
I mean,
a
it's
smile.
I think it's one of those opportunities you get that God just kind of puts in your face and says,
Mhm.
"What you gonna do?" Right?
Mhm.
So,
Absolutely.
anyways, so
I'd
that's
say
the other
I'm
thing.
crazy appreciative for being part of the team and for you bringing me in because
Well,
I've never been happier than I
I
am right now.
knew you had to work here. I told you how I heard about you. I kind of prayed about it. I knew you were going to work here. I just had this feeling. I was talking to a drug rep about like who would you send your neurology people to, or who do you like for neurology? And we have some good ones around here. And I was fully expecting her to say Dr. Bekovic because he's always done super good for our patients. And she said you. And I'm like, I found out later you were paying her. So good
Yeah.
job. Yeah, very nice.
It worked.
It worked. So anyways, and we're not looking to start any sort of neurology clinic here. But
Right.
I think where you've actually been a game changer is something that not I don't think you're trying to compete with anybody in town in terms of neurology patients, but
Just with them.
but you are elevating our game in terms of getting the right person to them, in terms of finding stuff, And so I would say anybody, if you just have a love for anything family practice and you feel like you've connected with Maria in any way on this visit today, just give us a call, and she would love. I mean, you see everybody, right? You'll see kids, anything?
Yep.
Awesome.
Pretty much everybody and anything.
Love it.
Yeah.
And there's nothing you won't see, right?
Yeah. Nothing I can think of.
So I can keep coming for my prostate exams.
Except for that.
Weekly.
You have to pay out of pocket. I'm going to charge you double.
Another, I know we have to go, but it's kind of funny. We should probably end on the texts that you got from me when I was recruiting you that may or may not have made you think that you didn't want to work here. And I was just laughing my ass off, literally trying to have fun. I don't know why. My sense of humor is way off the wall, right?
Yep.
And I have fun and I tell big whoppers and I just get going. All my patients know that. I'm the doctor that tells the stupid dad jokes in the room. But you didn't know that.
No, not at the time.
You didn't know anything about that, right? That I don't mind embarrassing myself. I've been on stage with and bad bands, and I've played terrible music in front of people who told me it was terrible, and I've done all that, so I don't mind embarrassing myself. And some of these texts I sent you, I thought I sent that. I'm like, I don't think she might understand or think I'm joking. For instance, was there one I sent you about if you get this job every month, Friday, nurse have to take turns clipping my toenails or something like that? Yeah,
absolutely.
Okay. What did you think when I sent that?
I was like, what the hell are you talking about? And I said to my husband, look at what he just said to me. And my husband's like, for sure he's joking. I'm like, well, of course he's got to be. This is too much.
Okay. At any point, because there was several others, and that was probably the one that sticks out the most to me. But
yeah,
at any point, did you think, I don't think I can come here. This guy's insane?
No, it was probably the opposite. Like you literally texted me like almost every day, if not several times a day, just random thoughts which I've learned now is your norm. You just have these random thoughts that come. So you would text me as you were thinking.
You get a choice. You either get me on Ritalin and you get no text, or you get random thoughts all the time. Like, there's, I thought this was a good idea. We should start this in the clinic like that squirrel that's running over there kind of test, right?
Yeah. So for me, it was kind of the opposite. Like it felt like you really cared. You really must want me to join the team. Otherwise you wouldn't keep texting me. I figured you would have just ghosted me and I wouldn't have heard anything more, but it just, I think, persuaded me and talked to me into coming here even more.
Awesome. Well, you've been such an awesome fit.
Thank you.
And would you say maybe the hardest thing about working here is that I'm married and just trying to control yourself? I mean, that's what I think.
Actually,
their major problem is, but I don't know. Maybe that's in my imagination.
Yeah,
I don't know.
That has not been a thing for me, so I think we're okay.
Okay, think about it. Do you really think? I mean, there has to be some struggle there, or I'm wrong.
Maybe we just need your wife here more every day.
Okay, is this going to turn into
her?
Okay?
We're missing her. She needs to be here.
Folks, if you hear me make some atrocious statement, I swear to you, this is just what I do all day. I'm never serious.
All day, every day.
If it sounds like I'm serious, I still might not be serious. So, God, this has been so much fun.
Yeah, thank you. I was nervous,
this is great.
but it was good. It was fun.
Okay, will you come back?
Yes, I will.
Okay, awesome. Very good. And actually, while we were doing this, we were actually texting each other because our spouses were trying to get us to go to this charity trivia tonight, of which, as long as it's medical, I'll be good. But anything else, not so much. My wife will kick my ass. Anyways, this has been an awesome visit. Thank you, Maria.
Thank
you can come see her. Yeah. Call 319-236-7720, I think is our number. But again, this is Dr. Rock. The information provided on this podcast is for educational and informational purposes only. It is not intended as medical advice and should not be considered a substitute for professional medical consultation, diagnosis, or treatment. Listening to this podcast does not establish a doctor-patient relationship with me or any guest on the show. Always seek the advice of your own physician or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay seeking it because of something you heard on this podcast. Use this information at your own risk.